Hello, I'm Judy Burleson, Director of Metrics at ACR, and I work very closely with MITRE and the registries, looking at measures, quality measures, performance measures that relate to or can be used in or about the registries. So I'm happy to be here today and to introduce this next session where we'll be looking at hearing from some facilities that are using the GRID, the National Mammography Database, and the CT colonography database, the registries. So our first presenter will be John Lough, who's the Director of Imaging Services at RMH Healthcare in Harrisonburg, Virginia.
Good afternoon. Now that's after lunch, my wife tells me my hearing is not well, so anybody that falls asleep and snores, I won't take any offense to that today. Just introduce myself. I'm the Director of Imaging Services, Centera Rockingham Memorial Hospital in Harrisonburg, Virginia. I've been in healthcare for about 30 years. I know you're thinking I look incredibly young to be in it that long, and thank you. But I started out as an x-ray tech many years ago, processing film, working in the dark room, and all those good things. So I have seen some evolution. Unfortunately, I'm now on the dark side of management. Just a little shameless plug here. This is our facility in Harrisonburg, and I'll introduce that a little bit more in a minute, but you notice the location. We're kind of out in the country. So in terms of shameless tourism plugs, we're 2 hours west and south of here. The leaves are pretty. Come visit us. Just a little bit, I want to tell you a little bit about our facility and a little bit about us so you understand how we're using the GRID metrics. We're a community hospital located in Harrisonburg, as I mentioned. We've been around, this is our 100th anniversary. We had been, until 2 years ago, located at a little 15-acre campus in the downtown of Harrisonburg in the city, and we're now on a 254-acre rural campus. So we've got a little room to grow, and it's been nice to be able to redo our services. We serve a 7-county area, population of close to 200,000. We're the largest agricultural county in Virginia. We have 3 colleges and universities, approximately 35,000 students in our area. And we did move to our campus in mid-June 2010. Like I said, we have 254 acres, 238 beds. Our emergency department sees about 72,000 or plus patients a year. We admit more than 16,000 inpatients, and our outpatient visits are about 192,000. So how we use the GRID data. When we began planning for our new replacement hospital back in 2004, 2005, we started doing a lot of process work. And as we worked on the plans for the facility, of course, we wanted to streamline, we wanted to improve our flow, patient flow and such through the building. And so we had an opportunity when we started collecting the GRID data in early 2010. What we were really excited about is we basically had 6 months worth of data that we could collect and compare and then look at the second 6 months after we moved into our facility and see if our processes really did work. And I'm happy to say they did. We could show that, and I'll show you some slides in a minute. What we did with that data, though, as we began working with the GRID metrics and getting the reports back in 2010, is we set up a group across the department and then by modality to really look at our patient flow, wait times, et cetera, and to say, okay, what are we doing? How do we get, when we're looking at this benchmark data in this report, what is it we need to do and how do we improve that? So one of the areas we focused in 2011, just because we were so new in our facility, we really just focused on wait times starting out. We had the data, and so what we looked at is for each of the modalities, we looked at if we were at the median, trying to do a 10% improvement. If we were not at the median, do a 10% improvement from where we were at. We were able to meet all of our goals back in 2011. Now, I do have to tell you, our organization created a success sharing program. And what this program was focused on, customer service, performance and quality improvement metrics, and financial metrics. And so every employee in the organization had hospital-wide goals, and then you set departmental goals. And so what we used in our department then for the PI and quality metrics to meet this success sharing program was a lot of the benchmark we had on wait times. And of course, when you put a little financial incentive in there, and my staff, I have about 150 folks in my department, they're very eager. They'll bet on anything. They'll challenge everybody or anybody in the hospital for anything. So when you put a bar in front of them, they're always going to want to jump through it. So as we moved through 2011, as an organization, we also raised that bar and that financial carrot, if you will, for the staff. We've raised it to a larger level, higher level, and so they have more money at stake this year coming up. And so we decided to look at, besides wait times and continue to improve that, to look at turnaround times, and for our radiologists, as we've worked with that group on their performance metrics, the percent exams signed within 12 hours for all modalities. So I just want to give you a little bit of some slides that we use with staff at staff meetings and how we pull our reports. And so just to give you an idea, this is our wait times in our x-ray department. And also to explain to you, our facility, we basically in our hospital commingle ED, inpatient, and outpatients. So outside of a few plain x-ray facilities in the community, CT, MRI, ultrasounds, everything's in one location. So it gets to be a challenge working on that wait time and getting those outpatients through in a timely fashion when you've got an ER and inpatient that's got to be taken care of. So you can see in January and June, for example, here, when we moved to our new facility, that first 6 months was based on our old facility. The second 6 months afterwards, you see a spike, and the pinkish line there was all of the groups in the grid measure. And you see we went up. We had a big influx of patient volume. We saw in 2011 approximately 10% growth in CT and MRI both individually, and about a 12% growth in our plain X-ray volume. Then you can see after that, as we continue to move on, we've improved those processes. And that's really the function of a lot of the folks as we sell these influx of new patients. The groups worked together, looked at these metrics, and set their bars and figured out how to do that workflow. So just a couple other areas, ultrasound. You can see in 2010, before we moved, our wait times were really poor in ultrasound. And our ultrasound department was buried in the middle of an old building, quite a distance from our waiting and check-in areas. And so we just had a real problem with that patient flow and patient movement. So the group, though, worked on it, especially when we got aligned in our new facility, and then they've continued to improve over time. I think it's interesting that all the sites in the comparison, the last 6-month report, their wait times have shot up. I'm not sure why that is. MRI, we've maintained pretty well, but again, you see a spike that we saw in 2011 due to patient volumes, and then we've taken corrective action and been able to drop those. CT scan, also, we've been able to stay down. We have not done as well as we have in our other areas, but you see that we've been able to get there. The last couple of reports, we've gotten under the median wait times. We also looked at our wait times for stat CT studies, with stat and routine studies. You'll notice we have a very low amount of wait for our stat studies, and we're well under the comparison. My suspicion is it's because we really redefined about 5 years ago what a stat study is in our organization. In our organization, if you order something stat, it means loss of life or limb within the hour. And so, because we all know how stat gets abused in healthcare and everything's stat, and the patient says, I'm at the mall, I'll be there in an hour, to get in. But anyway, that's our definition. And so what we wrote our policies and procedures are, if there's a patient that needs a stat study, that's really a phone call from that ordering physician to the modality. We clear a table. That patient is moving to our imaging site before we even hardly get an order in the system. That's all catching up as we go. But again, that's a really small number compared to what we used to see with the way the stat designation was overused. You'll see an area we don't do so well in, and that's our routine CT wait times. And again, we're in a department where we're mixing all 3 classes of patient. And so our routine wait time, while we're improving and we're getting closer to the median on that median, we're still not quite where we set our goals at as an organization. So what have been the challenges we've had getting involved? And really I'm going to echo what I think I've heard a lot of other people say today. It's that data collection. It's getting, for us, getting within a system and being able to extract the data in a good, concise form and make sure it's valid data. And being careful. I will mention that there's some metrics, I'll mention those in a second, that we want to get into. We haven't done a good job yet, because anytime you add a screen or a click point or a field to be entered, someone's always coming after your hide. You know, no one wants you to add more work just to collect data. So it's always a challenge to say, where can we pull this from? Where are we collecting it already that we can submit for our grid metrics? So for 2014, we're continuing to measure these use these same metrics, but we're adding things. We are a gold member of the grid collection, but we have a lot of holes in that we don't feel like we're getting good data yet. So we want to try to get digital radiography repeat rates. Some of you may be like me. It's difficult because you got to pull those from your systems, and every vendor has a different way of collecting that. And we try to collect that at the modality instead of out of packs, because that's not as accurate. There will be images stored at the modality that don't get transferred to packs. We also want to look at valid data for wrong exams, exams on wrong patients, and exams on wrong sites. And that's what I have. Thank you.